Hello, I'm glad you could join us today. Welcome to the webinar, The Shifting SUD Policy Landscape. My name is Angie Fiedler-Sutton, and I'm with the National Behavioral Health Association Providers. The National Behavioral Health Association Providers, otherwise known as NBHAP, is a national trade membership association that provides education and advocacy for behavioral healthcare providers and related entities. We are the leading and unifying voice of addiction-focused treatment programs. We provide membership benefits such as networking and access to compliance information, education opportunities such as this webinar and our Certificate in Addiction Treatment Marketing, CATM, and advocacy efforts to keep those in the industry aware of new laws and regulations that may be coming that will affect them. Working in the behavioral health industry or managing an organization in the industry can be incredibly complex and filled with ever-changing information. NBHAP gives you resources to stay on top of the rules and regulations for your organization to stay compliant. For more information about NBHAP, you can visit our website at www.nbhap.org. And now, it's my pleasure to introduce our presenter today. Andrew Kessler, JD, is a founder and principal of Slingshot Solutions, LLC, a consulting firm that specializes in behavioral health policy. His clients, past and present, include the International Certification and Reciprocity Consortium, ICNRC, the California Consortium of Addiction Programs and Professionals, CCAP, and Faces and Voices of Recovery. With 20 years of policy experience and over a decade in behavioral health, Kessler is a fixture in circles that advocate for substance abuse treatment, prevention, and research. He collaborates frequently with congressional offices, the White House Office for National Drug Control Policy, the National Institute on Drug Abuse, NIDA, the Substance Abuse and Mental Health Services Administration, SAMHSA, and other federal actors. Andrew has written legislation and report language adopted by both the House and Senate Appropriations Committee and has presented orally before such bodies such as the Scientific Management Review Board, the National Conference on Addictive Disorders, and the College on Problems of Drug Dependence. Andrew, thank you for taking the time to present today. With that, I will hand the webinar over to you.
Thank you, Angie, and good morning, everyone. For those of you on the West Coast, if there's anyone on the East Coast or in Central Time, good afternoon. A few housekeeping notes of my own before I get started. I am coming to you today from Fairfax, Virginia, right outside Washington, D.C., in my home office. And no one is home except for me and my beagle. So if you hear some barking in the background, I apologize in advance. She's a little antsy today because of the deer in our backyard. So other than that, we shouldn't have any interruptions. And the way I like to do this is I'll present for about 45 minutes so I can leave some time for questions at the end. If you have a question in real time, just put it in the chat box. My eyes are going to be going to the chat box every so often. And if you have a question, maybe I can get to it in real time if it fits within the bounds of what I'm talking about. If not, I will definitely get to it at the end. And let's get started. Here we go. Angie said, my name is Andrew Kessler, and I'm the founder and principal of Slingshot Solutions, a consulting firm that specializes in substance use disorder policy, as we have for about 15 years. You can follow me on Twitter at SlingshotDC. Feel free to tweet yourselves about anything you learn in this webinar, unless I say specifically not to, because I like to give you as much information as possible, and there are some things that just don't belong on Twitter. So with that, let's talk about what's going on in Washington and how it impacts SUD policy. We've picked a few major areas to talk about. We only have a little less than an hour, so we can't possibly talk about everything, but it's a real interesting time between last year and this year. We're in a real interesting place with SUD policy. First and foremost, we're obviously in a post-pandemic world. I've talked to you several times during the pandemic and coming out of the pandemic. Now we are fully out of the pandemic for the most part. At least we are legally. The public health emergency that governed the pandemic has been lifted. It was lifted in May. just about 3 weeks ago. And there are a lot of rules in place for a lot of areas of healthcare that were pandemic specific. And SUD treatment and SUD services, there were some rules that impacted us. When it came to MAT distribution, when it came to telemedicine, we're going to talk about those and how being in a post-pandemic world is kind of impacts those policies. So the first thing we're going to talk about is the distribution and the prescribing of buprenorphine. During the COVID emergency, telehealth patients could receive a buprenorphine prescription without an in-person visit with the doctor. Before the pandemic, you had to physically visit your doctor at least once in person before they could write you a prescription for buprenorphine. With people unable to leave the house as often, with doctor's office cutting back on who could see them, this rule was put in place that through a telehealth visit, buprenorphine could be prescribed if the doctor thought it was appropriate. As we knew the pandemic would be coming to an end and certain rules might be lifted or certain rules might stay in place, some chatter started to build up in DC, and we were starting to hear and starting to talk, maybe we could keep this rule in place. Patients seem to like it. Doctors don't seem to have a problem with it. And we haven't noticed too many complications with it. So we were all a little surprised that in March, the DEA proposed that when the COVID emergency would end, this rule would too end, and they would need to see a physician to receive a prescription. Or in the alternative of seeing a doctor before getting the prescription, they could get a prescription for 30 days, but they must see the doctor in person before it is refilled. This really didn't rub us the right way because this was coming off the heels of the abolition of the X waiver. And many members of Congress and the White House were very pro-buprenorphine and wanted to expand treatment. And we figured the best way to expand treatment would be keep this rule in place. Now, whenever a rule is created or offered, it has to go through a comment period. The public has an opportunity to comment. I don't know how many comments are submitted on average for rules such as this, but I can tell you it's less than 37,000. The public comment period produced 37,000 comments on the proposed rule. And as a result, the DEA delayed their final decision for 6 months. During this period, the emergency rule will remain in effect. So it's an excellent example of advocacy, having an impact. Not only will the rule stay in place for 6 months, but anyone who initiates contact with a physician to receive a buprenorphine prescription via telehealth in this time frame will have 1 year at least before they need to see the physician in person. So we were happy with the outcome there. We'll see what happens in 6 months, but the temporary rule went into effect 2 weeks ago and extends the full set of telemedicine flexibilities for 6 months, as I said. And then it will be reevaluated. So at least we bought a little time. In addition, we are dealing with some rule changes concerning methadone. Now, these changes are a little more, how should I say this, overdue. Methadone regs have not changed for decades, and I'm not exaggerating. Probably since the Controlled Substances Act was written in the early 70s. I think for 50 years we've had these rules in place with who can distribute methadone, how, in what doses, so on and so forth. During the COVID emergency, in order to get more people methadone in a safe manner and minimizing contact with others, things like mobile methadone clinics were allowed, take-home doses were allowed, and these programs were effective. So going in the opposite direction of the buprenorphine rule, the White House decided to expand on this. So whereas at first the buprenorphine rules seemed to be going back to pre-pandemic regulations, with methadone, we wanted to take the changes made during the pandemic, move them forward and make them permanent. As a result, the White House recommended a rule change to what's known as 42 CFR Part 8 concerning methadone access. So as I said, when the pandemic started, SAMHSA published flexibilities for methadone. It could be a 28-day take-home supply, or in some cases a 14-day take-home supply at the discretion of the doctor. And research shows these were effective. There was very little, if any, abuse or misuse of the methadone, and it was used for its intended purpose. So the research bore out that this was a good policy. So, as I said, a recent study showed that patients who received increased take-home doses after federal flexibilities were enacted saw positive impacts on their recovery, including being more likely to remain in treatment and less likely to use illicit opioids. I hope this is really a good groundwork for moving forward, because we still need a lot of changes to the methadone regs, and those could be coming in the near future. I know not everyone on this call works for an OTP provider, but it's an important, the changes in the methadone regs is important in the terms of how the federal government views people in need of this kind of care. Instead of insisting that they be, monitored extremely closely with someone constantly, checking on their progress, they're getting a little more discretion to do their own self-care, and it's working, which just goes to advance the position that substance use disorders is very like other diseases. When it is incumbent on the patient to exercise self-care, they're perfectly capable of doing it. So this slide is just a little more on the take-home methadone, as you can read. We heard a lot about telehealth during the pandemic, as I mentioned before, and its benefit to the rural community. There's benefits to urban communities too. People who live in urban communities who have to get to a methadone clinic, it's not easy often. Got to take public transportation, buses, you got to get there before work. It's not an easy thing to do. And in some areas, yes, it is a challenge. There are some states like, I believe, New Mexico that, outside the main city of Albuquerque, there's only 4 methadone clinics in the state. So, the opportunity for mobile methadone clinics and take home really reaches all populations. And all populations benefit, not just rural areas. Now, there's also been legislation introduced concerning methadone. Senator Ed Markey of Massachusetts, along with Congressman Norcross, are introducing legislation that would bring about a seismic change in methadone prescribing and availability. Methadone prescribing would be allowed outside of OTPs by either an ASAM doc or by a psychiatrist. So we're still limiting the prescribing power to people with a knowledge of addiction medicine and the disease, the substance use disorders and the neuroscience behind it, and the knowledge needed to make sure that the prescribing of methadone is the correct course of action. But once it is prescribed, it would be able to be distributed by pharmacies upon prescription. I didn't take too deep a dive into this legislation, but imagine like an own miniature OTP within a pharmacy. That's where we want to see this headed. Many of us who advocate for substance use disorders use the refrain, it's a chronic disease. let's act like it, let's treat it like one. Well, if you have the chronic disease of diabetes or the chronic disease of, a bad heart, you can go get your meds at the pharmacy. That's all we want for methadone. The argument against it for many years is the risk of misuse and improper distribution. Well, I just showed you the studies. It's not happening. The science doesn't back it up. So we're hopeful that maybe this can be the next step in methadone access. Methadone remains, in terms of the statistics, one of the most effective forms of treatment for opioid use disorder. So, the numbers don't lie. So we've got our fingers crossed that this can be a big step forward. Also coming from the White House in recent weeks is a emergency declaration on xylazine. Xylazine is a animal tranquilizer that has been appearing more and more often in the illicit drug supply. I know you're scattered all over the country. I see people from California. I see people from Oregon. I see people from North Carolina. But as with many illicit substances, there tend to be regional pockets, and the tends to spread from certain areas outward. Right now, xylazine is the biggest problem on the eastern seaboard. We see a lot of it in Philadelphia. We see a lot of it in the New England area and New York. So mostly eastern seaboard. I'm not sure how much xylazine is showing up in the drug supply in the Midwest and West. But it presents a real danger because xylazine is not an opioid like fentanyl is. Xylazine is a synthetic animal tranquilizer, and it's more like a barbiturate. And so when someone overdoses on a drug with xylazine in it and you administer naloxone, it's not going to be effective. Naloxone is designed to counteract opioids. This is not an opioid. So at the RX Summit in Atlanta in early April, at his plenary session, Dr. Rahul Gupta, the director of the Office of National Drug Control Policy, declared a xylazine emergency. Now, this is not an emergency like the COVID emergency. That was a public health emergency. This is something different, and this is the first time it's been declared. It's being declared an emerging drug threat. 5 years ago, the Support Act passed, and there was a lot of legislation in the Support Act that gave different agencies and different branches of government new powers to observe, detect, what have you. One was the ability for the Office of National Drug Control Policy to declare an emerging drug threat. This is the first time in history that a drug has been declared under these auspices. So xylazine mixed with fentanyl has been declared an emerging drug threat. What does this mean? It means ONDCP, the Office of National Drug Control Policy, formerly known as the Drug Czar's Office. We don't like that terminology. We don't use it anymore. We say Office of National Drug Control Policy, will be required to monitor novel and evolving patterns of use. They will establish criteria for determining when a substance or combining of substances should be designated as a threat, which they've done. And they've also put the director basically in charge with the ability to bring together other branches of government to coordinate on this. So there will be a lot more monitoring and a lot more data to analyze xylazine. They will be convening an interagency working group to inform the development of a response plan. I don't have a timetable on that. I think it's 90 days post-declaration. So the response will include work on testing, just like we have fentanyl test strips. We're going to need xylazine test strips, which do exist. and distribution in some areas like Philadelphia and New York has commenced. I'm not sure what the supply of xylazine test strips or the availability is, but they do exist. They will include treatment, supportive care protocols, data systems, like I said, and strategies to reduce the illicit supply of xylazine, as well as fast-track research on the interactions between drugs like xylazine and fentanyl. Okay, another issue, another big policy issue that we're dealing with is the SUD workforce. This is one of the most talked about yet least acted on issues when it comes to substance use disorders in Congress. You'll find many members of Congress say, oh, this is such a high priority for us. Yet they're very, very short on ideas for how to solve it. Workforce is really tricky because for decades, our workforce has kind of been piecemeal. We have SUD counselors. We also have social workers. You have some marriage and family therapists. You have psychologists and psychiatrists, addiction docs. It's a very piecemeal approach. When I say workforce, I mean SUD specialists. That is the area we're focused on. And I'm going to explain why in a few minutes. First things first, the Senate Health Committee, which is chaired by Bernie Sanders of Vermont and Dr. Bill Cassidy of Louisiana, who could not be two more different people, both agree that the healthcare workforce writ large is a major problem in this in this country. Now, when they say healthcare workforce, they mean everybody. Our position at BHAP is that we want to make SUD workforce a major part of this legislation when it comes to fruition. So an RFI, request for information, was issued by the committee in February. We met with members of the Help Committee, both majority and minority staff, to let them know how we viewed, some, first just to give them information, and second, how we viewed the ability to, expand our workforce. Quite often the answer on the Hill to a workforce problem is loan repayment. You say we got a workforce problem, that's the first place we're going to go, loan repayment. Loan repayment is a great tool for recruitment. Our problem in SUD treatment and recovery is not recruitment, it's retention. And you can keep adding people to the workforce. If they don't stay, you're really not building your building any higher. Or as I say, you've got a hole in the bucket. So I'm just going to go through a few slides about what our priorities are for SUD workforce. If you can see on this slide here, this is a chart published by HRSA, the Health Resource Services Administration. HRSA is responsible for health in underserved communities across the United States, as well as any public health and public health workforce that answers to the federal government, i.e. community health centers, public health, the National Health Service Corps, the Public Health Service Corps, federally qualified health centers, not community behavioral health centers. Those are under SAMHSA. But if you want to talk SUD workforce, you go to SAMHSA. You go to HRSA, excuse me. And what I noticed in chatter around Capitol Hill is that whenever there's one area, one group that says we have a workforce problem, everyone else tries to pile on and say, us too, us too. The numbers don't bear that out. What these numbers show is that the largest shortfall And the only shortfalls projected by 2030 are in two areas. That first column, adult psychiatry, and that third to last column, addiction counselors. These are the estimated supply of the workforce between 2017 and 2030, as well as the demand in terms of the needs of the population. All of these, except those columns I pointed out, shows a sufficient workforce by the margin of those numbers listed. If you see it in parentheses, if you're familiar with accounting, that means you're operating at a deficit. And where are we operating at the largest deficit? Psychiatry and addiction counselors. That's where we need to focus with our workforce policy, addiction counselors. We kind of hammered that point home in our meetings and our documents with the Senate Health Committee. I also want to talk about some criminal justice issues, and this is important because, unfortunately, if you're trying to help someone in the SUD world, odds are quite good that they have a past that involves a brush with the criminal justice system. And that's where our position or our analogy that, oh, it's just like any other chronic disease kind of falls a little short. No one goes to jail for being a diabetic. No one goes to court for having heart failure. But you do when you're involved with substance use disorders. It is in our current system, the two cannot be separated. The criminal justice system and SUD treatment and prevention are joined at the hip in our current system. So I wouldn't say half, but maybe 35% of our work is not really in the health domain. It's in the criminal justice domain. And it's allowances for health expansion within criminal justice settings, mostly jails and prisons. Those of you, I don't have the numbers for urban areas, but I want you to hear this statistic, and it's not in the slides. I'm just going to say it to you. If you are a rural county in America, you will spend on average 78% of your county budget on jails. Why is that cost so high? Because of substance use and mental health disorders. The number of people who are in jail or prison with a substance use or mental health disorder could be as high as 70 to 80% based on where you are located. I once met a man at a conference, at a behavioral health conference, and he introduced himself as the man who runs the largest mental health treatment facility in the world. I said, really, where are you located? He said, I'm the superintendent of the California state prison system. And he's right. If you want to find the largest mental health facility in the city of New York, you go straight to Rikers Island. No joke, the statistics bear it out. So what you need to know about the criminal justice system is that when you enter the criminal justice system, as soon as you are adjudicated, if you have Medicaid benefits, they are gone. So what happens is, if you want to get those benefits back, it used to be upon release, you had to apply and go through the whole process. And if in this time you needed Medicaid services, especially for SUD or mental health, you were out of luck. So what we have been trying to do for several years, what we finally succeeded in doing a little bit, is to allow the Medicaid clock to start tolling pre-release. So the federal government is now going to allow states, if they choose, to use Medicaid funds to provide medication-assisted treatment to treat SUD, as well as other medical services for people in jails and prisons up to 30 days before release. Here's why that's important. That way, the dollars go through Medicaid. And if you're an expansion state, this is great for you. The dollars go through Medicaid, and the states don't, and the counties don't have to spend those dollars from their own criminal justice budget. The way it works is once you are in prison or jail, they are on the hook for all your health care. We want to change that. And we want to say Medicaid should be responsible because Medicaid is far more likely to approve things like buprenorphine and methadone than someone in charge of a criminal justice budget would. So this is following up on a bill that passed last year that allowed juveniles to apply for Medicaid benefits 30 days pre-release. What we're trying to do in Congress is get that for the entire population. And now states can apply if they choose to use Medicaid funds for the same purpose. California was the first state to have a waiver granted to begin this process. As I mentioned, we're still working on legislation. One of them is something called the Reentry Act. This one has a chance. Most legislation, I'm not going to try and, kid you or I don't want to shatter anybody's illusions. About 2,000 bills are introduced in Congress every year. Very, very few pass. This one has some good bipartisan support. The number of Democrats and Republicans in both chambers who support it are about equal. We've got Northern Democrats, we've got Southern Republicans, we got a really wide cross section in favor of this legislation. And again, this legislation would make all Medicaid eligible incarcerated individuals to resume receiving Medicaid benefits 30 days prior to release. And like I said, this is already in effect for juveniles. Another piece of legislation that is a little more complex and doesn't have as great a chance is one that would allow people to retain their Medicaid, what we call pre-adjudication. That's the time from when you're arrested and arraigned, so you've been charged, to the time you stand trial. You could be in jail if you can't post bail, awaiting trial, and you have no Medicaid benefits. We're trying to change that. Say, look, if you're convicted and you're in prison and the law says no Medicaid, the state's responsible for you under the criminal justice rubric, umbrella. That's understandable, at least. This is, let's say you're out on bail or you're in jail being held awaiting trial. We want your Medicaid coverage to stay in effect. So we're working on a lot of different pieces of legislation that would allow this. Make no mistake, Medicaid is the largest funder of SUD services in the country. More than the block grants, more than private insurance. Medicaid, our lifeblood for SUD treatment is Medicaid. That's why expansion was so important when the ACA was written and passed. That's why it continues to be important. And the results speak for themselves. Take a state like Kentucky. Once Kentucky actually passed Medicaid expansion, the number of people receiving SUD treatment in one form or another increased 600%. Okay, so it's no joke. Medicaid is extremely important. Now we're going to talk about Medicare. This is an interesting area. Medicaid, as you know, is state by state, but there's still federal oversight. Medicare is 100% federal. And there's different standards for the two, which I'm not going to get into right now. But Medicare has a significant number of codes and coverage for mental health. It has very few for SUD. We're trying to change that. Medicare is an extremely efficiently run organization or payer. It may not seem that way sometimes for those of you who have to deal with them. I get it. But Medicare spends less money on administration and costs than any other form of insurance in the United States. Only 7 cents on the dollar. So Medicare is extremely efficient when it comes to the amount of money spent on care. So we are involved in an effort to expand Medicare coverage of SUD. And this is led by a group called the Legal Action Center, which fights for the rights of those who have substance use or mental health disorders who can't advocate for themselves. Our primary goal, our first goal, is to get Medicare to be able to cover inpatient SUD services. It is estimated that the cost of Medicare of adding SUD coverage for residential programs and intensive outpatient would be $1.9 billion annually to cover 75,000 residential treatment episodes. That's in Washington. I can never say this with a straight face. In Washington, that's not a lot of money. We deal in billions all the time. And I'm going to talk about that a little more in a few minutes, how we are dealing in billions and even trillions sometimes. You say to me, you say to someone, 1.9 billion in Washington, odds are good they may not blink. Which may be part of the problem, but that's a topic for another day. The interesting thing is that Medicare is what's known as mandatory spending. So it's much harder to advocate for. If there's a program like the SAMHSA block grant, the state opioid response grant, that's what's known as discretionary spending. Each year, Congress decides how to spend that money. Medicare is called mandatory spending. It must be covered by the federal government. No debate, it's covered. Whatever the bills are, they pay them. That's why Medicare coverage is so important, but very, very difficult to influence change because it is not under the jurisdiction of the normal spending committees. It's under the jurisdiction of the Senate Finance Committee and the House Ways and Means Committee, which make direct withdrawals from the U.S. Treasury, which is a very complex process. So we are trying our best to make these changes. It would be great, but this is a long-term effort, very much so. But as I said before, Medicare doesn't do enough to cover SUD. So we think that a change is in order given how efficient it could be. So, of course, when you're talking about Medicare costs, they would be partially offset by reduced costs from treating medical conditions caused by SUD. That could be hepatitis, HIV, could be MRSA infections, it could be endocarditis. 3 years ago, I don't have the most recent numbers. I know 3 years ago, Medicaid spent over $900 million on cases of endocarditis directly related to intravenous drug use. If you put something in your bloodstream, it's going to make its way to your heart. If you put poison in your bloodstream, it's going to damage your heart. So endocarditis, big problem. All of these things can be discovered for patients who can enter a course of care through Medicare. Collectively, we estimate these cost savings could become as much as $1.6 billion. So remember I said before, it would only cost $1.9 billion only. But the net impact of spending, the cost would only be $360 million. Again, to put this in context, total spending for Medicare in 2020 was $826 billion. We're not talking about a lot of money here. I see a question. Does this proposal include funds to pay for room and board or just the treatment services? I believe it is the treatment services. I do not believe room and board is covered. That is probably a question to be answered further down the road. But my guess, my gut, and I don't say this with 100% certainty, my gut tells me it's for treatment services. So but there is an argument to be made. I know Medicare does cover certain long-term care options for other areas. That's an interesting question that we have to look into. Okay, so I've got about 5-10 more minutes before I take questions. and we're going to talk about the fun part, which is what's going on right now, today, in Washington, D.C. It's funny, I was joking with Angie before the webinar started, and I said, usually when there's a big political fight in D.C., 9 times out of 10, you're like, oh, that doesn't affect us. Oh, funding for the war in Ukraine. No, that doesn't affect SUD. Immigration. No, that doesn't affect SUD. Pick an issue. The stock market. Well, that could affect it. But you see what I'm saying. The big political issues you hear about on CNN, MSNBC, Fox News, wherever you get your news, those big ticket items, by and large, don't impact the work we do. However, this does. What we're talking about right now with the debt ceiling and spending very much impacts the work we do in the SUD prevention, treatment, and recovery community. Okay? Last year, at the end of the year, the fiscal year 23 budget saw some moderate increases for the state opioid response grant, the substance use prevention, treatment, and recovery block grant at SAMHSA, as well as for the STAR loan repayment program at HRSA, which is the substance treatment assistance repayment program. This is just for SUD professionals. It's a program that's about 3 years old. So we saw some moderate increases. We saw the X waiver disappear. We had a decent year at the end of 2023. We were hopeful that maybe in 2024 we could keep it going. The White House seemed to be on our side. The way the process works, is that the White House proposes a budget. Congress must then approve the budget, and then the president has to sign it. So it's a back and forth. There's a saying in Washington: the president proposes, Congress disposes. That's only true if you're of opposite parties. So in the House, that may be the case this year. In the Senate, not so much. Before all of the debt ceiling arguments and the negotiations happened, what we knew was that the president wanted to see the block grant at $2.7 billion, which would be about a $900 million increase, and the SOR grant at $2 billion, which would be about a $400 million increase. Those are significant increases. But as you can see at the bottom there, that ain't going to happen. Why? Because of what's been going on with the negotiations over the debt ceiling. You may have heard that Speaker McCarthy wants to cap spending. He doesn't only want to cap spending, he doesn't want to cap defense, he only wants to cap what's called non-defense discretionary. That is everything that is transportation, education, energy, commerce, and health and human services. So, and Department of Justice as well, which can impact the programs we advocate for. So we were afraid originally that because HHS, Health and Human Services, which funds SAMHSA, which funds the Center for Medicare and Medicaid Services, which funds HRSA, which funds the CDC, we were afraid originally that they would have to absorb cuts of between 22 and 37% in order to pay for no cuts on the defense side, which we were not fans of. We were pretty clear that would be the impact on discretionary spending. As I said before, Medicaid is mandatory spending. We weren't quite clear on what the impact would be. Luckily, as the details of the deal come out, what we're learning is there is a proposed spending cap on FY 2024, which is next year's budget. It's being negotiated now at last year's levels. So at the very least, we won't see cuts. There is a 1% cap on spending for 2025, which means exactly what it says. Spending would increase by only 1%. This does not mean necessarily that all programs are capped across the board. This means the overall number way up here stays the same. And as the money filters down and transportation gets their piece, and education gets their piece, and health and human services gets their piece, there may be increases, there may be decreases. And then as HHS gets their number and money goes to CDC and SAMHSA and HRSA, some may increase, some may decrease. So when you hear that there's a cap on spending for this year and a 1% increase next year, that doesn't mean all programs across the board will be impacted equally. There is still a chance that funding can increase for these programs. There is still a chance that funding can decrease for all these programs. We are very, very, very much in flux right now. Those of my friends who advocate for heart disease, lung disease, diabetes, cancer, we're all in the same boat on this one. We are all in the same boat. So it's going to be a bumpy ride, you know, as I said in the earlier part of the title, buckle your seatbelts, you know, it's we're in for a bumpy night. This is going to be a very bumpy ride. The deal is expected, fingers crossed, to pass the House today and hopefully pass the Senate maybe by the weekend. Maybe. We have no idea what's in front of us in the Senate. We have no idea if Speaker McCarthy or Leader Jeffries can hold their caucuses together to get the votes for this. All I know is that this is a much, much, much better deal than we were worried about facing 5 days ago. I think I got this news at 9:30 Saturday night during a 3-day weekend, at which times I usually don't work. But all the alerts started popping up on my phone, so I started reading, 9:30 on a Saturday night during a 3-day weekend about the deal. And I got to tell you, my initial gut reaction was not bad. I'm not happy that defense gets an increase while we get decreases. I'm not happy that we're limited to 1% growth potentially. I'm not happy that members of Congress can go around trumpeting how dangerous the SUD issue is and then do something like this, which will have a very negative impact on funding the programs we rely upon to provide services. All that being said, if you work in Washington to get what you want all the time, you're going to go broke. So I've always said working in advocacy is a lot like working in treatment and recovery. You just got to keep plugging away, and you just got to hope that things break the right way, and mix your knowledge and know-how with a little bit of luck, and maybe things turn out all right. So, that's where we're at. It's going to be a really, really tricky couple of months. So that's all I have. I've gone about 45 minutes, which is how far I like to go. So if there are any questions, please go ahead and ask them. You can either put them in the chat box. You can ask them to Angie. I just want to address the one question in the chat box I see right now. What about the requirements to become a Medicare provider? That is indeed on the table. I can't get into specifics. I do have a document that I might be able to send to Angie, which she can distribute, that will get into that in further depth. But it is on the table. I just can't offer specifics right now.
While we're waiting for questions to come in, the webinar feedback form has been popped up. This is just a general evaluation of the webinar itself. It is not connected to the CEs. Just to let you know that you'll, as noted, you'll be getting an email either today or tomorrow with access information on how to access the CEs. We basically have to confirm attendance and all that before we'll give that out to you. Excuse me. Any questions, please put them in the chat. And then a reminder that, there we go. Lori wants to know, when talking methadone, will scripts be pills or liquids? Pills cannot be tapered as specifically as liquids.
I don't know how specific the bill is. I did not see any language concerning pills or liquid in the legislation. It could be doctor's discretion. The whole point of this is to say that if the doctor believes that a person is in need of this type of care, they should be able to receive it. I think that will be doctor's discretion, but if Angie can make a note to remind me to follow up, I'll do so. Sorry, Angie.
Emily wants to know what's the best. That's fine. No, Emily wants to know what's the best way to stay informed on current policy changes. It can be also overwhelming. I can answer that partially. We send out regular advocacy alerts through our website. Just go to nbhap.org and you can sign up there. They're usually sent out about once a week, give or take. You can also see what prior ones there. But aside from that, do you have any?
Oh, if you want to be honest, my LinkedIn profile. That's where I post all my professional updates. I mean, you could follow me on Twitter, but you're just as likely to get a tweet about how frustrated I am with the New York Giants as I am with Congress. It's kind of a hit or miss there, and language could get a little salty. So LinkedIn, I keep nice and professional, nice and clean, and I'm constantly posting updates on my LinkedIn profile.
Lori wants to know, how will pharmacies be able to stock liquid methadone?
I am not a clinician. I am not a pharmacist. Yeah. Sorry, not the answer you're looking for, but I do work closely. I will let you know this. I don't want to brush you off. I do work with a professional who represents the American Boards of Pharmacy, and she's very much involved in this effort. And just know that they're involved in this effort and are taking into consideration the different mechanisms that would be necessary to make this a reality.
While we're waiting for more questions, to follow up on those advocacy alerts, once a month also is one specifically, Andrew writes, specifically just for NBHAP members. You will not be able to access that unless you're an NBHAP member, and those go into a little bit, it's kind of a print version of what you had here today.
Right.
Of kind of updating you in terms of what's going on. So there's an incentive to become a member if you're not already.
Right. I see this question about methadone. It's like, I wish I were an OTP expert. I'm not. But I did stay at a Holiday Inn Express last night. That's that's the best thing I could say. When it comes to methadone, our position and our advocacy is focused on access. I know the devil is in the details, but the way legislation works quite often is once the law is passed, that's not it. A lot of laws will establish a new rule, a new standard, what have you, and then give power to the Secretary of Health and Human Services for the oversight that's necessary. So a lot of these questions on methadone, if the law does become reality, the Secretary of Health and Human Services would be expected to issue guidance that would be followed by the pharmacies.
While we're waiting, let me pull up your LinkedIn and put it
Sure.
in.
I see a question about mobile methadone clinics. As of now, that is not in the Norcross bill. As of now, the way a mobile methadone clinic works is it must be attached to it must be affiliated, with an actual physical OTP. You can't just build a van and say, Marge's methadone and go around and, start filling prescriptions and distributing. It is for existing patients of OTPs. And the van would be the property of the OTP, and all the same rules of distribution would apply, except that it's on wheels. So it's almost as if the OTP comes to you. That's how it exists now during the COVID emergency. And that's how it would probably exist under the rule change for 42 CFR Part 8. If there are to be changes in the future, those haven't been, pen has not been put to paper yet. So for now, the mobile methadone is attached to an OTP. I'm going to tell you, there's another organization out there that knows far better than me about the rules and regs of methadone. It's called ATOD, the Association of Opioid Treatment of Opioid Dependence, and this is the association of basically of OTPs. Their positions may be a little different than NBHAP's in terms of specific regulatory changes they want to see take place, or specific, all the questions about, liquid versus pill and what's best. They're the real experts, but I don't want to deny you any resources. So, and like I said, I'm not a clinician. I'm not a methadone expert. I'm a methadone policy expert. So I'm going to put their link in the chat. And ATOD has a lot more information available about the specifics of methadone that you can educate yourself, and maybe even in the future educate me. Makes me a better advocate. I love to learn. That's why I enjoy these webinars and I enjoy conferences. I get a chance to talk to people on the ground, and the more I know about the subject matter, the better I can advocate for it. So.
Jim wants to know if there's anything in the bill that specifies MAT clinic ownership. Monopolization is happening in many states on this, he says.
No, there's nothing. And what's interesting about law and government is if it's a monopolization issue, it probably, I can't say for certainty, but I do have a degree in law, and it probably takes that issue out of HHS and parks it squarely in justice, because that is a antitrust issue. So even though it's about MATs, the issue you're talking about, monopolization, is the purview of the Department of Justice, not the Department of Health and Human Services. So that's a whole nother set of ears you got to get to listen to you. And ATOD, may know more about that.
Any other questions? Rosemary says, my client seems to have a hard time getting buprenorphine without going to a bunch of doctors. Will this change? Will more doctors be able to give it to clients? Is that something you know?
The X waiver is history. Those of you familiar with that, there was a required DEA training course that would allow you to have a license to distribute buprenorphine. That is no longer the case. So by the letter of the law, that should increase the number of physicians who can prescribe buprenorphine. However, even before that, when the X waiver was in place, we saw numbers, and I'm paraphrasing here, but it was something to the effect of 4% of physicians who had the ability to prescribe buprenorphine accounted for like 70 to 80% of the actual prescriptions. It's not the X waiver, so I know there used to be limits on the number of patients, and there used to be limits on who could prescribe. That's all changing. But that was never the issue, in my opinion. The issue was not the regs. The issue was, do the doctors have it within them to take on this population? That's always going to be the issue. So by the letter of the law, on May 31st, 2023, as compared to December 30th, 2022, before the law was passed, is it easier for patients to access buprenorphine from a doctor? It's supposed to be, but we don't have any data yet, and the data we have is not reflecting, it is reflecting what I suspected. The number of prescriptions is not increasing like we hoped it would, and I still think the root of that is the number of doctors who are hesitant to engage in the treatment of substance use disorders.
Jim wants to clarify, so any doctor can prescribe them, but whether or not the doc does so is up to them?
Yeah, you still need to complete a DEA, it's like a 2-hour certification, but it's much less than it used to be. Yes, any doctor can do it. It's a matter of, whether they want to put it out there that that's what they do. It's a whole nother discussion about, substance use in society that we could have a whole nother webinar on. So, so yeah, it's I think it's really much more of a I hate the S word, but I'm going to use it, the stigma. It's much more of a stigma issue. Personally, I heard someone say at a conference once, it's really not stigma, it's discrimination. I prefer that, but we use the word stigma. It's too many people, both in society and in the healthcare profession, do not understand the ins and outs and neuroscience and complexities of substance use disorders. And I think that's what's holding us back, not doctors' ability or a regulation. So maybe we could talk about that the next time.
And with that, we are out of time. Thank you. I want to thank Andrew Kessler for presenting today. Thanks as well for you for participating. We hope you join us for future BHAP webinars. You can sign up for our various newsletters, which includes emails specific to upcoming events, as well as advocacy alerts at our website, www.nbhap.org. With that, this concludes today's webinar. Thank you very much.